Hello and welcome to the Year 1 Module 3 training for behavioral health. My name is Sarah Moore. I'm the Senior QI Lead for MyMind and my pronouns are she, hers. And I'm excited to discuss with you over the next hour how QI can support suicide prevention care pathways for behavioral health. We'll start the training today with reviewing the MyMind suicide prevention care pathway recommendations for behavioral health, as well as briefly discuss how primary care and behavioral health can work together to create a pathway that is streamlined and support each other's mutual goals of keeping the patient as safe as possible throughout their healthcare experience. We'll then shift to discussing the risk assessment pilot, your first quality improvement assignment in which champions and liaisons will work with clinic teams to test a change in processes to work towards increasing suicide risk screening using the Plan Do Study Act or PDSA process. Next, I'll provide some helpful information on creating and implementing your first PDSA cycle. We'll wrap up this training with a reminder of some tools and resources available on the MyMind Partner portal, starting to build your suicide prevention toolbox, as well as cover key takeaways and references. We are happy to have you here. As always, sit back, relax, make sure you're taking good care of yourself during the training, and thank you for being here today. Just a reminder here that support for MyMind is provided by Blue Cross Blue Shield as part of the BCBSM Value Partnerships program. Although Blue Cross and MyMind work collaboratively, the opinions, beliefs, and viewpoints expressed in the training do not necessarily reflect the opinions, beliefs, and viewpoints of Blue Cross or any of its employees. In the last training, we provided recommendations for scenarios for patients with active or passive suicidal ideation and started talking about the care pathway for suicide prevention. Today, we will revisit the recommendations MyMind has provided for individuals at elevated risk for suicide and how the Zero Suicide Risk Assessment informs the care pathway for behavioral health. We will also discuss best practices for behavioral health and primary care providers when patients refuse behavioral health treatment and how we can best support each other to enhance safety for these patients. First, let's revisit the suicide prevention care pathway for behavioral health. So, behavioral health and primary care should include consideration for each other's roles in suicide prevention. These care pathways should flow from one into the other, as this is what the behavioral health care pathway would look like once referred from primary care. Behavioral health and primary care can create one integrated care pathway for suicide prevention, if that's helpful, especially if using collaborative care. And here you'll see with this care pathway, it starts with the patient presenting to behavioral health at the top left-hand corner. This could be to see a therapist, psychiatrist, or behavioral health care manager. The patient is first screened with the PHQ-9. This helps with identifying risk, as well as starting to stratify risk for behavioral health providers, as that answer to the item 9 of the PHQ-9 and the overall score on the questionnaire may let us know that a patient is at elevated risk. The provider then completes the Zero Suicide Risk Assessment to explore more about the patient's risk and protective factors as they complete their usual biopsychosocial assessment. While obtaining the patient's history and completing the suicide risk assessment, providers should always inquire about access to lethal means. You can see in the same box that it states that the provider should complete the risk assessment. There are also some brief interventions that we know are evidence-based to reduce suicide risk. So that's just a reminder there of evidence-based interventions that you might include throughout your session. All providers should be giving lethal means counseling and asking about access, as well as consider what other brief interventions can be added as protective factors, including creating a safety plan with the patient or involving any of the patient's social supports in their care. Providing the 988 Suicide and Crisis Lifeline and text number, as well as community referrals, can also support patients in between appointments. After the behavioral health provider has completed the zero suicide risk assessment and determined the patient's level of risk, there is some guidance to suggest how soon the patient should receive psychiatric evaluation and some possible treatment options for each level. Over the next few slides, you'll see those broken out so you can see them a little bit closer as we go through each risk level. And just a reminder here that you can find this care pathway on the document library of the My Mind Partner portal if you want to get a little closer look. Patients should receive a psychiatric evaluation same day if having any of the risk factors you see here on the screen for acute risk, including active plan and/or intent. We went over these in the last training, so I won't name the risk factors for each risk level, but you will have the slide deck to refer back to after the training. Typically, this patient would be sent to the ED same day for evaluation. However, if the behavioral health provider deems a less restrictive level of care is needed, depending on the patient's risk and protective factors, a partial hospitalization program or an intensive outpatient program may be suitable for an acute patient. We did add some consideration that are crucial to consider for acute patients, including if they have strong support systems outside of the treatment team and outside of the clinic, and if there is any access to lethal means. If a patient is considered acute risk and is not going to the emergency department, a safety plan should be completed with the patient for them to review and use in between appointments. For each risk level, especially those who are at acute risk, My Mind recommends that behavioral health update the patient's primary care provider and treatment team and continue to do so to partner and promote patient safety. We also recommend that the patient continue to get screened and assessed for suicide risk at each subsequent appointment. So even though you might not see that blue circle as a reminder to follow up with primary care on the upcoming slides, it is important to keep them in the loop for patients at any risk level. For patients at high risk, it is best to receive a psychiatric evaluation within 48 hours. Although this may not be ideal, uh, to be seen, an ideal patient to be seen in collaborative care, or we also call it COCM or COCOM, or even outpatient psychiatry may be able to assist with starting somatic treatment, including psychiatric medication, as well as making an appropriate referral to a higher level of care if needed. So although collaborative care is usually for mild to moderate risk, and this patient might need more than outpatient care, an outpatient psychiatrist or collaborative care psychiatrist may be able to help support this patient. In a scenario in which the patient has compounding medical or social factors, it may be best if a high-risk patient is admitted temporarily to ensure safety. Again, we want to help this patient get to the next best, safest place, provide any additional interventions that can support the patient's self-management, and circle back with the primary care team to keep them informed. My Mind suggests that individuals at moderate risk receive a psychiatric evaluation within 7 days. Again, we provide the different risk factors for each bucket here on the care pathway so that you have them at a quick glance. A patient at moderate risk could be a good candidate for collaborative care or outpatient behavioral health services, but may also benefit from a PHP or IOP or chemical dependency program, depending on the patient's risk and protective factors, history of substance abuse, etc. Keep in mind that problem-solving therapy, cognitive behavioral therapy, especially CBT for suicide prevention or CBT-SP, as well as dialectical behavioral therapy or DBT, are evidence-based for suicide prevention, and may be useful modalities to consider when working with patients at moderate or high risk level. Remember that all patients seen in behavioral health have some risk level, even if low. For those individuals that are low risk, next steps would depend on the provider's clinical judgment and discussions with the patient. Although those brief interventions and patient self-management strategies can be helpful for patients at any risk level, we particularly want to consider supporting patient self-management for our patients at low risk, as they will be having less frequent appointments and will be more likely to have a shorter duration of treatment. Handouts with 988, QR codes that you can call, text, or chat the 988 number, the community support group info, and other patient-facing MyMind handouts can support the patient to manage emotional distress and proactively prevent symptoms from worsening. Again, behavioral health should continue to keep primary care informed of any updates, and the patient will continue to be screened and assessed for suicide risk at subsequent appointments. For all behavioral health suicide prevention care pathways, we suggest following zero suicide guidelines while coordinating care for your patient. First, always monitor the patient environment in the clinic. This should be true for patients at any risk level. Again, we always want to make sure a patient is as safe as possible, regardless of the risk. This becomes particularly important when patients are deemed at higher risk, especially if having plan or intent to die by suicide when coming into their appointment or having a virtual or on the phone appointment. All patients should be screened and assessed for plan and intent and immediate danger while coordinating care. All patients should be asked about lethal means access and receive counseling and possible support with removal if warranted at their initial visit. Lethal means counseling should be revisited at subsequent appointments, especially if the risk level increases. Involving a support person or support people is recommended for those at higher acute risk as much as possible. Collaborative safety planning is recommended for patients at moderate or higher risk. Providing resources and self-management tools can be helpful for patients at any risk level and can include anything from universal resources like 988 handouts that everyone gets, or more tailored resources such as support groups, websites, or books that may be specifically helpful to a patient's circumstances. It is best to have the patient, to give the patient multiple ways to access support outside of their appointments. We recommend that you follow these zero suicide guidelines for behavioral health and refer to the appropriate level of care necessary for the patient, depending on the level of risk, protective factors, and clinical judgment. Keep in mind that you may need to sign a release of information to talk to the patient's primary care doctor, psychiatrist, or therapist if they are outside of your PO. And it is best to keep them updated regarding any changes in risk level, medication changes, or treatment updates, as well as any changes to emergency contacts and safety plans for patients at elevated risk. So we had went over timeframes that we recommend for patients to receive psychiatric evaluation. We also want to provide recommendations for psychotherapy referrals. If a psychiatrist or collaborative care manager is referring to psychotherapy, we suggest that the referral is placed on the same day of the appointment for those who are moderate to acute risk. For acute risk patients, most of the time these patients in this scenario would be referred to the emergency department for evaluation. So psychotherapy and psychiatry appointments would be scheduled for post-discharge. The patient should have a therapy appointment scheduled within 72 hours of discharge. If high risk, the patient should be scheduled an appointment with a therapist within 5 days. And if moderate risk, the patient should be scheduled for a therapy appointment within 7 days. If the patient is considered low risk, the referral or need for ongoing psychotherapy relates to the patient's current needs and response to treatment. If a patient is already in treatment with a psychotherapist, the frequency of contact or appointments should be dictated by any change in risk level as well as response to treatment. These are just slightly different than our recommendations for psychiatric evaluation. For example, we recommend patients receive psychiatric evaluation within 48 hours if high risk. We understand that behavioral health access is limited and that these timeframes may be difficult to meet. Although we have heard of innovative ways providers are managing limited access to behavioral health, one model that we know is helpful to bridge that gap is the collaborative care model. So, how can we partner with primary care to prevent suicide? One way is to leverage the collaborative care model, again, also called COCM or COCOM. This model was developed out of the University of Washington and brings together behavioral health, primary care, and the patient to form a strong partnership devoted to improving mental health. In this model, the behavioral health care manager sees the patient, and instead of the patient meeting directly with the psychiatrist, the behavioral health care manager, or BHCM, consults the psychiatrist, and the psychiatrist makes recommendations to support primary care and the BHCM on pharmacotherapy. This can often help meet those timeframes recommended on the prior slide, as instead of seeing 1 to 2 patients in an hour, the psychiatrist can consult on multiple patients with the BHCM and work very closely with them and the primary care provider. It is a short-term treatment program that brings together primary care and behavioral health to treat patients with mild to moderate behavioral health symptoms. Collaborative care programs tend to have quick access to appointments and rapid access to psychiatric consults. For this reason, we recommend leveraging the collaborative care model to complete risk assessments and bridge care if there is no immediate access to traditional behavioral health services. Here is just a reminder that we also suggest that primary care create a suicide prevention care pathway. And you'll see the care pathway we recommend for through my mind here on the screen for primary care. This care pathway starts with the patient entering the primary care doctor's office in the top left-hand corner and being screened with the PHQ-9. The pathway is driven by the suicide risk screening, particularly the answer to item 9 of the PHQ-9. There are times when primary care may reach out to behavioral health for consultation or support, or just provide a warm handoff to ensure that a patient can be seen within the recommended time frame, or the behavioral health provider can check in with the patient within that recommended time frame. Behavioral health is considered in the primary care suicide prevention care pathway as well. You'll see in green um, is where behavioral health is considered to do suicide risk assessments and continue to work with the patient to provide evidence-based treatment that will support suicide prevention. The most important thing is that there is consideration for each other's roles in the care pathways that are created. Now, patients do have the right to refuse a behavioral health referral if they are not at acute risk or do not warrant same-day evaluation via the emergency department, or they're just not in immediate danger. As much as we would like these folks to get in and talk to a therapist or psychiatrist, there are some individuals that may not be open to this option, at least not yet. For these patients, it is especially important that providers, including primary care, follow the zero suicide guidelines after a positive screen on that item 9 of the PHQ-9, as well as primary care doing watchful waiting, which means having the patient come in more frequently for appointments to check in if they are not under behavioral health care. So we are suggesting not only that therapists or psychiatrists do the things listed here on the screen if a patient is not willing to follow up with the behavioral health. We are also suggesting that primary care provide lethal means counseling and assessment, involve support people, provide self-management tools. Primary care receive the same training materials as behavioral health on these tools from Module 2, and create a collaborative safety plan as much as possible. We do suggest that if a patient scores a 1 on item 9 of the PHQ-9, primary care considers a call to the behavioral health partner for a quick consult. And if a patient scores 2 or 3 on item 9, we strongly recommend that primary care reach out to their behavioral health partners just to make sure that there's nothing that they should be considering to make sure that that patient is safe. For psychotherapists whose patient is not interested in seeing a psychiatrist at this time, it can also be helpful to reach out to a fellow behavioral health provider and or a psychiatrist to team the case and consider any possible additional resources or supports, especially for patients with several risk factors and lack of social support or other protective factors. All right, so here I just wanted to pause for a second. We just discussed the primary or the behavioral health care pathway for suicide prevention and talked about how primary care and behavioral health can include some consideration for each other's pathways and make sure that they are mutually supporting patients. So I just want you to take a moment here and think about what your suicide prevention care pathway looks like in your clinic and where there might be any gaps or possibilities for improvement there. Okay, now we will shift to discussing your first quality improvement assignment for my mind, the risk assessment pilot. So we've discussed how we use the PHQ-9 as our gold standard of care for suicide prevention. We are asking that each practice champion support their team with completing a 2-week pilot at their clinic. So who all will be involved? Practice clinical champions will collaborate with clinic staff to implement a change in processes to promote identifying patients at higher risk for suicide, complete the one-page PDSA form for the MyMind QI lead team to review, score, and provide feedback. So what are we asking? MyMind wants you to start with screening patients to identify risk. So considering screening patients with that PHQ-9 or maybe even the PHQ-2 plus item 9. The pilot will run for a 2-week duration, and you have from today until May 1st, 2026 to complete the 2-week pilot and complete your PDSA form on the MyMind Partner portal. We are asking that each MyMind practice complete the pilot. This can be done for virtual or in-person appointments. Why are we asking this? Because we know that running a pilot or a PDSA cycle can help test a change. Practice clinical champions and their teams are likely to test several different changes or complete several different cycles before deciding to implement a change more widely. I know some of you may be familiar with the Plan, Do, Study, Act or PDSA cycle, so you'll be getting a quick refresher today on this. For those of you that are not, a PDSA cycle is a test of change in processes and procedures. In this case, participants will be testing a change in screening processes to try to increase suicide risk screening at each practice in their first year of MyMind. The PDSA is a continuous quality improvement process that is perfect for testing small changes iteratively over multiple cycles to help refine and streamline procedures effectively and efficiently. First, plan the change that you want to test. In this case, related to your clinic screening process. Consider how you will collect data to know if this test was an improvement or not. In the second step, you do what you planned. You will run the test on a small scale for a 2-week period. Next, study or analyze the data and results and compare them to your predictions. Did the test improve screening rates? Finally, in the last step, you act. Make a decision based on what you learned from the test. Will you adopt the change to your clinic's procedures? Will you revise the test and complete another cycle? Or abandon this test and start fresh? Then the cycle starts all over again as you start to plan for your next steps. Due to tests being run on a very small scale, it usually takes multiple small tests of PDSA cycles prior to making big changes in a clinic, department, or healthcare system. All right, so now you know a little more about a PDSA cycle and what we will be asking for you for this upcoming risk assessment pilot. At this point, you should also be aware that the Zero Suicide Guidelines suggest administering the PHQ-9 questionnaire to every patient at every encounter, using item 9 to specifically screen for suicidality. Every patient, every time, right? So next, we start at baseline. Consider, are you or other providers in your clinic screening for suicide risk at all? What is a small change that you can test to work toward improving screening efforts in the clinic setting? I provided a couple of examples here to get you thinking. We have some different variations, including support staff passing out the PHQ-2 plus item 9 or the full PHQ-9, or even some other kind of screening, including providers asking about history or current suicidal ideation. So you could use a screener, or you can even screen verbally and document that in the chart. So looking at the examples here, one example is that provider G, whose clinic's primary care doctors have been giving the PHQ-2 annually, will try administering the PHQ-2 plus item 9 for all of provider G's patients for 2 weeks, from May 6th to May 17th, 2026. So this is one provider in the clinic testing screening with the PHQ-2 plus item 9. Another example is that all of Dr. X's virtual appointments are sent the PHQ-9 via the EMR to complete for 2 weeks. And Dr. X follows up during the appointment if question 9 is higher than 0. So here we're focusing on one provider and their virtual appointments using the PHQ-9 during those 2 weeks. The change can be tested by all the providers at the clinic or a select 1 or 2 to start. The change can also be made for certain types of appointments, like starting with only in-person or virtual appointments. You have a lot of room to be flexible here, and we really want you to consider what is most feasible for the clinic and your staff. Remember, you are implementing a small change on a small scale to start. Now, what if your clinic is already administering the PHQ-2 or the PHQ-2 plus item 9 or another suicide screening measure? Then you're good to go, right? Well, one, it is fantastic that you are already screening, and we are happy that some participants are already doing screening in their clinics, but we can't let you off that easy. We do want you to consider any opportunities for improvement in your practice's suicide risk screening practices or protocols. So take some time to think about any potential adjustments that you can be made to your clinic's suicide prevention strategy or care pathway. It might even be helpful to work with some team members to get some input on processes supporting patient safety at your clinic that you could test out for a 2-week duration. So think about, what would your advanced mode be, and starting to work towards that. Remember that we do ask you to pick something specific to suicide risk screening. And keep in mind that the PHQ-2 does not suffice for that suicide risk screening, as you must add that item 9 to screen for suicidality. While we want you to complete the PDSA to test a small change to support increasing suicide risk screening at your clinics, we know that this may be totally new to you, and you may still be learning about PDSAs and quality improvement. We want you to know we don't expect it to be perfect, and we appreciate your efforts. Here's just a reminder, PHQ-2 does not count. You have to add that item 9 to be screening for suicide risk. So I gave you my rough introduction of PDSA cycles. The Institute for Healthcare Improvement, or IHI, has a nice video that gives you a little more background and history on quality improvement in PDSA cycles if you want to check that out. The link is here. And IHI also has some really good resources for supporting quality improvement using the PDSA cycle. So I added their website here too. That will send you all to the Quality Improvement Essentials Toolkit. We'll also be sending out those links after the training. So you might be thinking, where do I even start with my PDSA? Creating a SMART goal can help you start your PDSA strong and support the process throughout the cycle. SMART stands for specific, measurable, attainable, relevant, and time-bound. We will go through each of these aspects over the next few slides. So there are some important questions to ask prior to starting your practice's 2-week pilot. Most importantly, what is the goal of the PDSA? For this PDSA, we know that it will be something related to increasing suicide risk screening at your clinic. We are suggesting starting with screening because we know that you have to first identify the risk to mitigate it. It's helpful to think specifically about the details, such as what questionnaire or strategy is best to use for your PDSA, and who will your target population be? Maybe the target population is one provider's patients for that 2 weeks, or maybe it's all the patients having appointments in the clinic during the 2-week period. So if a practice is trying to screen every patient every time for 2 weeks to increase screening rates, what would the denominator be? It would be the number of patient appointments during that 2-week period, right? All of the appointments possible. In that same example, think about what would the numerator be. So the numerator would be the number of patient appointments in which suicide risk screenings were completed. So if a clinic sees 320 patients appointments in 2 weeks, and 190 of those appointments had a screening associated with it, 320 would be the denominator, and 190 would be the numerator. And that clinic would have about a 59% screening rate. Thinking back to the SMART goal, we want it to be measurable, but also reasonable. If a clinic is only screening annually with the PHQ-9 prior to the PDSA and is testing screening every patient every time for 2 weeks, it would be unreasonable to expect that clinic to get 100% during that 2-week period, right? It might be easier to start with a goal of screening 50 or 60% of the patients during the 2-week PDSA. How will we measure the change and know that it was an improvement? Utilizing the EMR when doing screening can be helpful with measuring change, as you may be able to leverage reports and audit charts easier. And if screening is not built into the EHR, consider can charts or provider notes be reviewed for support with this. It's important to gather data on the clinic's current procedures and rates. For example, what is the current screening rate prior to running the 2-week test? This is your baseline. So whatever your clinic's current screening rate is where you're going to start. That's your baseline. You will then be able to compare the data from the 2-week PDSA to your baseline to see if there is an improvement. It's important to know which staff members will track the change, whether this be in the EMR or via chart review. And this is something that non-clinical staff, such as an office manager, might be able to help with to support suicide prevention efforts. Consider what data you will track and how you will track it. So for example, the staff member assigned to this role may be tracking PHQ-9 scores during the 2-week pilot. Remember, the data can be tracked along the way if that's easier, and you do not have to wait until the end of the PDSA cycle to gather data. So you can either gather data daily, weekly, or at the end of the PDSA cycle. Prior to starting your pilot, make some predictions as to what you think the outcome will be. Now, the goal for your PDSA should also be attainable, which means it can be reached in the allotted amount of time. You may not have time to work with IT to get a new screening system in place in your EMR and complete your PDSA on time. In this case, you may need to reconsider what you will do for this PDSA and continue to work on that for an upcoming cycle. Similarly, if you think it will be difficult to get all the providers' buy-in in the clinic to screen every patient every time, you may want to start at a smaller scale or have a lower goal for your screening rate for your PDSA. Consider what steps need to be taken before, during, and after the pilot, and who will be involved. One example is somebody needs to make copies of the PHQ-9 for the person at the front desk to distribute. If you run out of copies, that will be no good. People will be missed. So ahead of time, thinking about things like that. Consider all support staff that could assist with executing the plan and measuring outcomes from the pilot. And again, this can be anybody from the front desk back. So front desk, MAs, nurses, primary care providers, psychiatrists, psychotherapists, case managers, social workers, office managers. Anybody can be involved. And remember that you have the flexibility to make this as feasible as needed. Your goal should be relevant, meaning it is related to the outcome you want to achieve. Is the goal of the PDSA working toward increasing suicide risk screening in your patient population and supporting suicide prevention? Remember, again, using the PHQ-9 would not be relevant here since it is not considered a suicide risk screening. Make your goal time-bound and your PDSA time-bound, meaning able to be completed within a certain amount of time. So the PDSA due this year is due on May 1st, 2026. So that cycle should by May 1st be completed, the results studied amongst your team, and information from your PDSA should be entered into the My Mind Partner portal. Consider what your timeline needs to look like to do this and give yourself some wiggle room to plan your PDSA with those at your clinic, as well as gather and analyze the data. On the next few slides, I'll walk through entering the information for your PDSA on the portal. Over these next slides, you'll see some screenshots of the My Mind Partner portal PDSA manager and providing an example here of a PDSA. So once you have your information gathered, or at least your plan, you can log into the My Mind Partner portal and click on the PDSA manager. To start a new PDSA, click Create a New Lineage. This will cause a new PDSA for your PO to be viewable on the PDSA manager. You can then click on that to open it and click Edit for you to start filling it out. Note that you can start to put information in for your PDSA form and come back to it to edit or add details, or put all of the information into the form at once your PDSA is done. Also note that the first 3 questions are not required or scored and are more so brainstorming questions that can help you and your clinic team to set aims and work towards your plan. The first quality improvement questions ask, what are you trying to accomplish as you start to formulate your plan? I'll be sending out the same PDSA example in a worksheet to you all after the training, but I'll go through the answers here as well. This first question is, what are you trying to accomplish? And in the example, the clinic staff is working on screening patients for suicide risk that are coming in for their primary care appointment to alert the provider that the intervention is needed and possible referral is needed to behavioral health. The long-range goal is a suicide reduction, a suicide attempt reduction, and suicide death reduction to reach 0 suicides. The second question is, how will we know that a change is an improvement? Remember that you want to make your goal in PDSA measurable. For this example, the champion stated that they will know that that there was an improvement if they were able to screen more patients for suicide risk, identify the patients at risk, and coordinate follow-up care. We can measure this by tracking how many PHQ-9s are administered, how many patients answered above 0 on item 9, and how many patients answered more than 2 or 3 on item 9, as well as track how many referrals were made to behavioral health. Now remember that these are brainstorming questions, so it's okay to throw kind of multiple darts at the wall here. It is important to start to consider your numerator and denominator as you're brainstorming. And the third quality improvement question asks, what changes can we make to accomplish the goal? Here, the champion stated that they will start screening every patient for suicide risk at every appointment and provide support to those at higher risk. So again, these don't have to be perfect by any means. They are absolutely brainstorming questions. We might read through them, but we will not consider them when we are scoring. Now, this following section in the PDSA manager is required and will be scored by the QI lead team, starting with the plan section of the PDSA. The first question here asks what your team plans to do. Here, the champion states that they plan to complete a 2-week pilot of administering the PHQ-9 to every patient at every encounter. This will start April 6th and end April 17th, at which time the process will be reviewed to determine the effectiveness of the pilot. In the plan section, there is also a portion where you can state what your prediction is for your PDSA under "We hope this produces." For this, the champion stated that they hope for increased screening for suicide risk to identify the need for further assessment of suicide risk, as well as identifying any needs for further intervention and support from the provider and care team. Now, there is a section below that provides some areas where you can input some action steps, who they are assigned to, and a target completion date. Although this section is not required, it can be helpful to keep your team organized and on task. So if you wanted to add those action steps in, you would just click on the green Add New and add as many tasks as you would like, and that's helpful. On this slide, you will see a screenshot of the Do and the Study sections of the PDSA Manager. Under Do, consider what happened when your team ran the test during the 2-week PDSA cycle. In the example, the champion writes 178 patients out of 211 possible patient appointments were screened for suicide risk with the PHQ-9. 20 answered greater than 0, 9 answered greater than 1. Approximately 33 patient encounters did not receive PHQ-9 screening or did not have results entered. And a few patients were frustrated with having to complete the questionnaire. So just adding any observations there. Under the Study section, the champion or liaison, whoever is filling out the form on the portal, will write what the team learned or concluded from the cycle and what made it successful or unsuccessful. Keep in mind that a good PDSA may not always have the same results as you predicted, and that a good PDSA is not always a successful one. The most important thing is to learn from the experience to support ongoing quality improvement. Under the study section, we have the example of the team here, feeling that they were successful in giving out the PHQ-9 to most patients, and that this worked well as a clinic process for them. They also noted that it was helpful in identifying patients at higher risk. Regarding barriers, there was some difficulty in putting the PHQ-9 scores into the EMR in a timely manner when staffing was short or one or more MA was off. And some of the staff involved felt that it would be helpful for staff to receive further training on suicide prevention and the resources available. Another important observation is that half the patients who answered 1, 2, or 3 on question 9 would not have been identified as being at risk without the pilot, since they were not coming in for a behavioral health related appointment and would not have been screened with the PHQ-9 otherwise. Lastly, the champion or liaison will complete the ACT section. This is where you choose what the team's next steps will be after the PDSA. You will see on the screen here, you have some options to choose from. First, your team can choose to adopt the change that you tested, as they did in our example. Maybe it went so well and the clinic staff are ready to implement the change more widely. Your team may also choose to revise the test and repeat another cycle. Maybe you noticed a bottleneck in your observations and you want to slightly change the process to account for this and try that in a second cycle. Or maybe your team would feel better doing another cycle for an extended amount of time, maybe a month or so, or increasing their target population before implementing the change fully. The team might also decide to abandon this test and start a new PDSA cycle. There are multiple reasons why you may pick any of these, and there is no wrong answer. Now, there is an option to choose Other, in which we ask that you do provide a little more context on what your next steps are if you are not choosing to adopt, revise, or abandon. Just remember to change the status from In Progress before you make your final edits here, as well as hit the Update button at the bottom each time you update your PDSA, and when you have completed your PDSA and want to submit your final version. Just hit that Update button at the bottom. And if you would like to revisit the example that I provided, again, I will send a worksheet out with the example I've provided here after the training. The handout also has some helpful reminders on setting SMART goals for your PDSA. But you can also access that worksheet by clicking on the dark blue rectangle at the top of the PDSA manager that says View Example of Completed PDSA, as well as find that in the document library. At this point, you have completed your PDSA with the support of the team at your practice, input the information into the MyMind Partner portal, and submitted it for review. After May 1st, the MyMind QI lead team will start to review the PDSA that you turned in and that others have turned in, score them based on the PDSA rubric you see here on the screen, and provide the champion and liaison, if applicable, with feedback on their PDSA to support future quality improvement efforts towards suicide prevention. For each section, timeliness, completeness, quality of content, originality, and care pathway principles, there is a total of 3 points possible, and the goal is to receive a 14 or greater to be able to receive credit for your PDSA. If your practice receives a 13 or lower, the champion and liaison will receive feedback on the PDSA and have the ability to remediate their PDSA to receive full credit. Note that the reasons for remediation are often that the write-up wasn't clear or data was missing. So just remember to be thorough and detailed with your answers. And I will send out the full PDSA rubric along with your confirmation email for attending training, so you will be able to review that full PDSA rubric to help guide you when you're completing your PDSA and writing that up. All right, so check out the tools on the MyMind Partner portal. in the document library under training documents. There will also be an example of the PDSA that you will fill out on the My Mind Partner portal that we went over. And for your next steps, start to think through your practice's suicide prevention care pathway and ways to improve your practice's current care pathway, especially related to screening. Complete the 2-week risk assessment pilot at your clinic, and complete the PDSA form on the My Mind Partner portal, due May 1st, 2026. And here I just wanted to give a shout out to the My Mind tools that we have put out on the My Mind Partner portal to support our participants, and remind you about these if you haven't gone into the document library on the My Mind Partner portal and checked them out. We have some patient-facing tools, including PHQ-9, GAD-7, crisis hotline, and community health support groups. We have some handouts on DBT and cognitive problem solving for our behavioral health participants to utilize when working with patients. We have some really good patient-facing handouts called "If You're Thinking About Suicide, Read This First," and a couple handouts that could be good for loved ones, including understanding and helping someone who is suicidal and preventing suicide tips for parents. Provider-facing tools to support My Mind participants with recognizing risk factors and protective factors for suicide include a template for behavioral health to utilize to complete the Zero Suicide Risk Assessment, for primary care providers to be aware of as well, and to be able to have a quick glance at acute and high risk factors and protective factors. We also have handouts on weapon safety, lethal means counseling, creating a safety plan. We have some examples and templates for carrying cards and safety plans. So make sure you check out those provider-facing tools as well. And some of the most important tools we reviewed in year 1 are our primary care and behavioral health suicide prevention care pathways. We hope that these can help you all start to form your suicide prevention care pathway at your clinic to work toward giving you some examples to improve your care pathway. So make sure to give those a look when you get a chance. Again, just a reminder here, your PDSA is due May 1st, 2026. Our key takeaways are creating a standard suicide prevention protocol and care pathway can support providers, patients, and their social support team when a patient is in crisis. A suicide prevention care pathway can help providers to know their role, best practices, and what resources are available to support a patient at risk for suicide. Using quality improvement tools, such as the Plan, Do, Study, Act, or PDSA cycle, can help explore ways to strengthen suicide prevention practices, including increasing suicide risk screening. And when completing a PDSA, start small. You can always complete subsequent cycles to broaden your PDSA's reach. Use a SMART goal when starting the PDSA to ensure the goal is specific, measurable, attainable, relevant, and time-bound. And again, regarding your next steps, we are now asking that you complete a 2-week PDSA on increasing suicide risk screening efforts. You'll be inputting that information into the My Mind Partner portal once you completed the 2-week risk assessment, and we'll be giving you some feedback on those, providing you with even more education on PDSA and quality improvement coming up in year 2. All right, here are references from today, always included. You can reach out to myself directly or to the My Mind Coordinating Center at the email here. We also want to recognize that as providers, you may struggle too, and we always want you to know that as much as we want you to pass out and give out 988 information to your patients, we want you to use it as well. So please feel free to use any of the resources that might be helpful for you. Reach out to PO leadership, reach out to us, let us know any way that we can support you, but always make sure you're taking good care of yourself. And congratulations, you've completed all the My Mind trainings for year 1. So just wanted to say thank you for all you do daily to support your community and support suicide prevention across the state of Michigan. Again, feel free to reach out to the My Mind Coordinating Center if you have any questions, and I hope you guys have a great day. Thanks for listening.